Welcome back. Today I am joined by two doctors who are here from MemorialCare Saddleback Medical Center. We have Dr. Paul Drury and Dr. Ashish Shah, who are both cardiac electrophysiologists. Well, welcome both of you. Thank you for joining me.
Thank you for having us.
Yeah, thank you for having us.
So we're going to talk about Afib and also a new procedure that's Watchmen. So let's start with you, Dr. Drury. Why don't you tell me what Afib is?
So atrial fibrillation is actually the most common irregular heart rhythm. And it affects upwards of 3 million people in the United States and upwards of 35 to 40 million people worldwide. It's something that impacts the older population more than the younger, with upwards of 15 to 20% of people over the age of 85 carrying a diagnosis of atrial fibrillation. Now, what atrial fibrillation is when your heart's normal rhythm or sinus rhythm gets taken over by an irregular rhythm. So there is a chaotic irregular rhythm that is generated by the upper chambers or the atria of the heart, and these will take over and cause a chaotic irregular heart rhythm. Now, the issue that causes AFib is often multifactorial. Age can do it, heart conditions, high blood pressure, diabetes, or some healthy people even get it. Now, what the problem is atrial fibrillation, since it's irregular and it's an inefficient heartbeat, can cause blood to stagnate. And when blood stagnates, blood clots can form. And when a blood clot can form, if it leaves the heart, it can lead to stroke or other conditions where an embolism or a blood clot can go and block off blood supply to certain organs.
Okay. Now, how long have you been a cardiophysiologist?
So I've been an electrophysiologist practicing here at Saddleback for about 6.5 years.
See, I keep getting those mixed up. I apologize.
No problem.
So wait, you're both are cardiologists.
We are both cardiologists. So we are cardiologists who specialize in cardiac electrophysiology.
Oh, well, there you go. Thanks for that clarification.
Yep.
I hope I'm not the only one that does that.
No, most people don't even know that we exist, so that's okay.
Well, that's a terrible thing to say. All right, well, let's talk about, because obviously it's a very important subject because, I mean, you know, the numbers that you were throwing out, that's an awful lot of people that are dealing with this. So let me just rephrase we'll talk about both of your backgrounds. So quickly, Dr. Drury, tell me your background.
My background, I'm a local Southern California guy. Did my medical school at University of Southern California and all my training at the Harbor UCLA Medical Center up in Los Angeles and Torrance.
Okay.
After that, I've been practicing locally in Orange County for now about 6.5 years here at Saddleback and in Laguna Hills. My specialty, as we said, is cardiac electrophysiology. So what that means is I'm an electrical specialist for the heart. So one way people can look at it is once you become a cardiologist, there are the general cardiologists who treat a little bit of everything. Then you have the plumbers and the electricians. The plumbers fix the arteries, the electricians fix the electrical work. And so Dr. Shaw and myself are both electricians. And so what we do is we deal with the wiring of the heart. And so we treat conditions such as irregular heartbeats, which can be both fast and slow, do both medical therapy, and then you can do procedures to treat the heart conditions. And those can include pacemakers, defibrillators, or cardiac ablations. And so that's what we do.
Okay, and how about you, Dr. Shaw? Where did you get your education?
I'm from Central Illinois, so I'm a Midwesterner, and I went to medical school up in Chicago and also did my medical training out there. Then I went to the Northeast to do my training in cardiology and further training in electrophysiology, with the last stop was at Beth Israel. And then after that, moved out here, which it's been about 2.5 years now, goes by quickly. Also, as Dr. Drury had mentioned, an electrophysiologist specializing in rhythm disorders.
Okay. So I know that you had given us some numbers, and I don't think we really talked a little bit about age. So we talked about, as you know, older folks. Can this also happen to younger people?
It could also happen to younger people, although it's much less common in younger people. In some families, there's a genetic predisposition where multiple family members will get the condition at a young age, let's say under 40, but that's very rare. Other people who unfortunately develop heart conditions at a young age, whether it's a valve problem, thyroid disease, accelerated high blood pressure, things like sleep apnea, can also lead to an increased rate of atrial fibrillation. But despite all of those, generally under the age of 60, 65, less than 1% of people have atrial fibrillation. But it does happen. It does happen.
Okay. Now, traditionally, treatments, there have been a variety. I think you mentioned pacemaker and a couple of other things. So let's just talk a little bit about those types of treatments.
Okay. So traditionally, treatment for atrial fibrillation is really twofold. The first, as I mentioned, with one of the problems with atrial fibrillation and the biggest risk and the biggest thing we worry about with atrial fibrillation is it can lead to a stroke. So the first thing we always do when we see a patient with atrial fibrillation is assess their stroke risk and develop a treatment to prevent stroke, or at least decrease the risk of stroke. Now, some really young, healthy patients have very low stroke risk, and we can get by without using blood thinners or any specific treatment. But the majority of people, especially over the age of 75, high blood pressure, people with heart failure or diabetes, require more intense treatment to prevent stroke. And that classically has been in the treatment with anticoagulants or oral medications that thin the blood. Mm-hmm. We used to only have warfarin or Coumadin, which is modified rat poison, which is what we use. And people would need to go get their blood tested frequently. Doses would need to be adjusted carefully. And there were many interactions with medications and foods. Over the past 10 years or so, newer agents have come out that can be given in a standard dose, which are as effective with a lower bleeding risk and better safety profile than warfarin. So that's the classic treatment for atrial fibrillation to prevent stroke. Okay. The other aspect is, what do we do with the rhythm? Some people were able just to control the heart rate and use medications to keep the heart rate regular, in the regular range, which would be, let's say, 60 to 100 beats per minute with medications. Other times, if people are very symptomatic and they feel the atrial fibrillation, and those symptoms can include palpitations, racing heartbeat, shortness of breath, dizziness, chest pain, or even some people will pass out from this, we like to get a little bit more aggressive. So then we can use specialized medication to keep the rhythm out of atrial fibrillation. Now, these are called antiarrhythmic medications. Or in some cases, we recommend procedures, things like cardiac ablation, to try and eliminate the atrial fibrillation and keep it normal rhythm with or without other medications.
Okay, now before we get into a device that you want to talk about, Dr. Shaw, can you tell me, is there anything in particular that people can do to prevent this from happening?
Yeah, so I think, as Dr. Dre had mentioned, the risk factors that are included, I think the big picture is maintaining a healthy lifestyle. It's prevention of disease. By preventing disease, you prevent your incidence of atrial fibrillation. So if you are a person that ideally has a healthy lifestyle, preventing the development of things like diabetes or high blood pressure, that speaks volumes for your potential for reducing your risk of developing further issues down the road. Now, let's say you already have diabetes or high blood pressure or even sleep apnea. Careful monitoring and treatment of those diseases, keeping them in check, will help reduce the strain on the cardiopulmonary system, and therefore reduce the risk of developing atrial fibrillation down the road. Unfortunately, it's not 100%. So you can do all the right things, and we have, Dr. Drury and myself take care of a number of patients that are, 50, healthy, active living, great in shape people, but they still develop what we call lone Afib, and can sometimes be highly symptomatic from that as well. So risk modification and living a healthy lifestyle is the biggest thing. And if you do have chronic comorbidities, making sure you're treating them, actively following up with your physicians that are involved in your therapies, and being compliant with your therapy is extremely important.
Yeah, I would imagine that it's hard for some people, especially when you talk about sleep apnea, because nobody wants to use that machine. So how do you convince them, to use that stuff?
That conversation comes up every day. And I think any EP that talks about AFib talks about sleep apnea. And the reason is because there is a direct correlation between sleep apnea and atrial fibrillation. And we know by consistent therapy and intervention with your sleep apnea that the AFib is markedly reduced. And how do you convince them? That's the question that always comes up. The old teaching of 21 days to make a habit, is one component. To stick with it, suffer for 3 weeks, and see if you can tolerate it. But the big thing is, a lot of people have explored sleep apnea a few years ago and didn't ever revisit it, and then now have AFib. So what I tell them is that there's a lot of new devices, breathing apparatus that are much more comfortable, people are much more compliant with as well, that may they're more likely to be compliant with that therapy. So I would highly recommend them to revisit their sleep specialist or whoever diagnosed them with sleep apnea to look at their options and possible interventions.
Right, and I think there's new technology surrounding those types of devices as well. So hopefully they'll keep improving on those, and nobody will have to wear the big mask anymore. All right, so let's jump into the Watchman. What is the Watchman device?
I think that question was for me, so I'll start by trying to answer as best as I can. So the Watchman device is a small device that we implant through the femoral vein. So that's a single access site, less than a size of a pencil, into the vein of the upper leg. We are able to then manipulate this device into an area of the heart called the left atrial appendage. Now, the left atrial appendage is the area of the heart that is most commonly associated with clot in atrial fibrillation. So the most common location for where the stroke comes from. So by closing this area off, we're able to decrease the risk of someone having a stroke. Now, the beauty is, a lot of people, as we talked about before, need to be on blood thinners to prevent stroke, but there's a large percentage of the population that struggles with recurrent bleeding being on blood thinners. So the Watchman is a device that we are able to implant, exclude the area of the heart where blood clots come from, therefore decrease the risk of stroke, and we are able then to stop using high potency blood thinners and then decrease the risk of bleeding. So we'll be able to show you an example of what the Watchman device looks like, but it's a metal cage with a mesh covering, and it sits snugly inside an area of the heart called the left atrial appendage.
Okay. And then how does this differ from some of the other procedures that you mentioned? Is it simpler? Is it an easier recovery?
It's a completely different procedure. So the other procedures we mentioned, whether it's medications, blood thinners, or pacemakers, are all things that actually affect the heart rhythm and try and keep the rhythm normal. The Watchman doesn't do anything of that sort. It is solely to prevent stroke. And the reason we do this is, despite our best efforts with medications and ablations, often atrial fibrillation does recur at some point down the road. We do a pretty good job, but there's still a high enough recurrence rate that we oftentimes will recommend people stay on these blood thinning medications. Right. Also, one of the treatment plans is just controlling the heart rate. So we know the atrial fibrillation is going to continue, and so the blood thinning medication needs to be on board. So what the Watchman device does is just prevents the need for long-term blood thinners and reduces the risk of stroke. It does not affect the heart rate, or it does not regulate the heart rate in atrial fibrillation.
So Dr. Shaw, is the only person that, or the only patient that really would benefit from this is someone who is on blood thinners, or who would be a great candidate for this?
Yeah, so as Dr. Drury mentioned, the biggest population we focus on are the ones that have had a bleeding risk or an issue. But let's take, for example, someone that for whatever reason, they're considered higher risk and they never went on blood thinners. So I don't want the patient to think, oh, I'm not on a blood thinner, therefore I don't need the Watchman procedure, but I have a Fib. It's a conversation we want to have with the patients. It's outreach and it's a matter of education. But basically, most patients, I think, that are 60 years and plus that have a Fib should ask the question, is Watchman right for me? And what we focus on are not just risk factors for patients of who is more likely to need it, but also their history. If they've already had a GI bleed or bleeding in their GI tract, whether it be blood in the stool, in their urinary system, and blood in the urine, whether they've had a hemorrhagic bleed from some other issues, any other part of the body. But it's not just that. It's also, we look at people that are high risk. So maybe someone has to be on blood thinners, has had a stroke history, has a Fib, but also has a high risk of falling. They haven't had a bleed yet, but we're worried about them falling and having a traumatic bleed. That's another person that we'd want to include in this protocol for screening for Watchmen. And then people that engage in sometimes high risk activities. So I have patients, we both carry patients that 75 plus that have risk factors for stroke, that have a Fib, and then they like to mountain bike still, or they like to do certain things. So we have this conversation with them. So I think, generally speaking, to determine if Watchman is right for that individual person, it's a conversation with the appropriate physician. And myself and Dr. Drury, we're all happy to have that conversation. There's a number of cardiologists in the area that don't necessarily put in the Watchman device that we do, but they do have those conversations on a regular basis with their patients. So again, the public service announcement is, if you have AFib and you're 60 plus especially, talk to your cardiologist about it. Talk to your cardiologist about this Watchman device.
So, Dr. Drury, you mentioned that it was very small, the size of a pencil. So I would imagine then that the recovery is fairly easy?
Yes, the procedure is done. It's minimally invasive. I said it's all done from a very small access site in the groin. Takes about 1 hour on average. Generally, it's a one-night hospital stay, but even that night, you'll be walking around and being able to do a lot of the normal activities. We recommend no strenuous activities such as working out, lifting anything heavy for probably at least 10 days after the procedure, but that's really about it. So right afterwards, we'll be able to eat, walk around after about a few hours of bed rest, and then home the next morning and back to normal activities almost within a couple days, and then back to the
Okay.
gym even in a week or two.
All right. Well, great. Well, thank you both for the information. I appreciate you taking the time, and we will see you again.
All right. Thank you.
And we'll be right back after this.